Good afternoon. This is Brian Callanan, the Executive Director and founder of the Cystic Fibrosis Lifestyle Foundation. And we are pleased to bring you in collaboration with CFresh, the Cystic Fibrosis Reproductive and Sexual Health Collaborative that has partnered with the CFLF's Strollo University this fall semester. We've want to acknowledge support from the Cystic Fibrosis Foundation's Community Impact Grants and collaboration with the University of Miami and Dr. Ramasi from the University of Miami's Urology Department. Dr. Ramasamy is the Director of Reproductive Urology as well as an Associate Professor at the University of Miami in Florida. As a urologist and microsurgeon, Dr. Ramasamy specializes in the treatment of disorders of male infertility and sexual dysfunction, and an expert in vasectomy, reversal, and penile prosthesis. Dr. Ramasamy completed his urology residency training at Weill Cornell Medical College and New York Presbyterian Hospital. He then completed a National Institute of Health sponsored fellow in male reproductive medicine and surgery at Baylor College of Medicine. In addition to his clinical accolades, Dr. Ramasamy has been integral to the advancement of male reproductive medicine and surgery. To date, he has published over 350 manuscripts in peer-reviewed journals and several book chapters. He currently serves on the editorial board of Andrology, Asian Journal of Andrology and Urology, as well as the editorial reviewer for medical journals such as the Journal of Urology, Fertility, and Sterility, European Urology, and British Journal of Urology. Furthermore, he has been invited to lecture at numerous international conferences, including the American Urological Association, Chinese, Malaysian, and Indian Society of Assisted Reproduction. Outside of clinical medicine and academic research, Dr. Ramasamy has made a significant effort to share his wealth of knowledge and serve as a mentor for future urologists. He created Urology as an app used by trainees across the world to help prepare for urology board examinations. As a physician, Dr. Ramasamy maintains a dedication to patient care, academia, and the training of future urologists by directing a fellowship program in andrology. And today, Dr. Ramasamy meets with us to present on issues that the male cystic fibrosis community often are faced with and unknown issues that are arising in the CF community. So Dr. Ramasamy, thank you so much for joining us today, and I'll hand the microphone over to you.
Thank you. Thank you very much, Brian, and thank you all for participating. And for those of you listening to it recorded, thank you for listening to this. I'm very happy that we're finally getting together. We've known this problem exists in men with CF for a very long time. But I'm happy that we're educating in some ways each other about issues that are pertinent to both patients who suffer from this condition and also for doctors to understand what options there are for men with cystic fibrosis. This is my disclosure. We recently got a grant to study male fertility among CF survivors from the CF Foundation. Thank you for that and for obviously supporting such an effort. So what we are going to do today is try and understand a little bit of the anatomy of the male reproductive system, and then specifically focus on anomalies in cystic fibrosis. What happens in cystic fibrosis? Why is the anatomy different? We're going to talk about decreased fertility that happens with cystic fibrosis and why that is the case. And then finally finish off with what are some of the potential fertility treatment options that are for men with cystic fibrosis to father a biological child. I don't need to educate this group about this, but in 2020, there's over 30,000 people with cystic fibrosis living in the United States. About 15,000 of them are male. This topic was not very relevant about 5 years ago, but now with the advent of Trikafta, which is the CFTR modulator, the life expectancy is increased. People are living longer. And now suddenly reproduction, family building, and starting a biological family has all become important to couples now, in which the male partner suffers from cystic fibrosis. And more patients with CF are now interested in fertility, their reproduction, as well as their sexual health. So we'll start with some of the basics of urogenital anatomy. The testes are where the sperm are made, and where once the sperm are completely manufactured within the testes, this squiggly structure right around the testis is called as the epididymis. This is where the sperm completely mature. It takes about 60 to 65 days for sperm to completely start from a germ cell, which is the first cell which starts making sperm, until the final sperm right before maturation. So it takes about 2 months. So anytime patients ever ask me, doc, I'm going to take this medicine, I'm going to stop taking this medicine, I'm going to stop smoking, what's going to happen to my sperm count? Anything will change, but it'll change in about 60 days, because that's how long it takes for one cell to completely become a sperm. And then once the sperm gets transported to the epididymis, which is right around the testis, there it takes about 2 weeks for it to mature completely. And from the epididymis, the tube-like structures is relevant for the topic today, which is why I'm stressing on this, is called a vas deferens, which basically takes the sperm, transports the sperm from the epididymis all the way down to the prostate and the seminal vesicle. And from there, it gets into the ejaculatory duct, which then goes into the urethra and semen is produced. So what happens during ejaculation is that sperm basically get propelled from the epididymis to the vas deferens, and from the vas deferens, the seminal fluid from the seminal vesicle, which are basically structures right behind the prostate, both produce the ejaculate, and it gets propelled outside into the urethra. So what happens in cystic fibrosis? So about 98% of men, very few don't have this condition. So 98% of men with CF will have complete absence of the vas deferens. And so the part of the epididymis will be missing and the vas deferens will be missing. And so they are technically infertile. There's very few times where we label a guy saying this infertile, where there's no way for you to conceive a child naturally. And unfortunately, CF is the one condition where we tell pretty much patients who don't have any vas deferens that there is 100% chance. We rarely use the word 100% in medicine, but in this case alone, there's 100% chance you cannot conceive naturally. And the first time the patients hear that, it's always very hard to digest, especially if they are married, and especially if they have never been informed that throughout their life. And I think as providers, people listening to this talk, let's try and educate this as soon as possible when patients actually get diagnosed with cystic fibrosis. Maybe at an early adolescent stage where now patients are actually exposed to reproduction, sexual life, and so on. And so the earlier they learn about this, the more informed they can be about their life decisions and life choices. So very important. I think we just educate them that if they miss the vas deferens, they cannot conceive naturally. And so what happens to all of the sperm? Basically, all of the sperm get made in the testis into the head of the epididymis and stay within the head of the epididymis and gets reabsorbed by the bloodstream. That's what happens. So the cells that are, the sperm cells that are made just get eaten up by the cells like phagocytes and macrophages, which basically eat up all the cells that are dying. And basically all of the sperm die within the epididymis and get reabsorbed in the bloodstream. So if the vas deferens is absent, and if the part of the epididymis is absent, what is also missing is the seminal vesicle in these patients, because the embryology of the vas deferens and the seminal vesicle is both coming from the exact same structure called the Wolffian duct. And so if both are missing, patients with CF will also tell you that they've never had a large ejaculate volume. They usually make 1 or 2 drops at the time of orgasm, because most of the ejaculate volume gets actually made by the seminal vesicle. These are the large structures behind the prostate that make most of the semen. So it's not because they are missing the tube that takes the sperm that is why their ejaculate volume is low, but because the patients who miss this tube will also miss the seminal vesicles. And so therefore their ejaculate volume will also be low. So patients often come and ask me, doc, forget about fertility, but my ejaculate volume is low. Is there something that I can do to improve my ejaculate volume? Unfortunately not, because you're also not just missing the tube that takes the sperm from the testis to the outside world. You're also missing these 2 large structures behind the prostate that actually contribute to about 95% of the semen volume that is not present in them, which is why their ejaculate volume is low. So anytime we ever look at a semen analysis report, when we see a very low ejaculate volume with no sperm, one of the first things that comes into my mind is cystic fibrosis, or they're missing the tube that takes the sperm outside. So what happens when the actual Vas deferens is absent. So how do these patients actually present? Sometimes in patients without cystic fibrosis, I saw a guy yesterday who has a bilateral absence of the vas deferens, meaning they don't have CF, they carry a variant of the CF gene or a mutation. And so they have absence of both the vas deferens. Sometimes you can just have one tube missing. So remember that 2 to 5% that said that sometimes they can be fertile. That's what happens within CF. Some patients will have one tube and not the other tube. And as long as you have one tube present, sperm from the testis can actually be transported to the outside world. So the good news is that most patients with CF will have normal testis size and normal hormone levels. So when I mean normal hormone levels, I'm talking about normal testosterone levels that will make them look like a man. So most of them will not have any problems with testicular size, penile size, erectile function, libido, growth of hair in the armpits, in the pubic area. And so they will grow up just completely fine and look like normal people. They just will not have that vas deferens. Good news, because there is testis size is normal, most of these men with cystic fibrosis actually have normal sperm production. They will have good sperm production, just no way for that sperm to come outside. And only on thorough exam by a urologist can the vas deferens be actually identified or not identified. Having been in practice for so many years, I can tell you I have missed a vas deferens myself in patients without cystic fibrosis. And so patients always ask me, Doc, can we just order a test? Cystic fibrosis pulmonologist doctors or ask me, can I just get an ultrasound of the testes? Can I get an MRI of the testes? Unfortunately not. Vas structure is just so small that only with a physical exam can you actually tell whether there is a vas or not. No amount of diagnostic tests or expensive diagnostic imaging tests will actually identify the presence of a vas deferens. So what happens when the epididymis is absent and the vas deferens is absent? All of the sperm basically stay within the testis, and only when you have some way to get the sperm out are we actually going to get the chance of biological children. So why does these happen? Why do these anomalies happen in men with cystic fibrosis? Number one, we think because of the mutation with the CFTR mutation, the whole tube basically starts forming in the fetus and then basically obliterates completely. And if the vas deferens obliterates completely, then the seminal vesicles also get obliterated. So when you do a transrectal ultrasound in men with CF or in patients who don't have vas deferens or CBAVD, like we talked about, you'll see a nice normal prostate gland, but behind the prostate, you'll see atretic seminal vesicles. These are like shrunken seminal vesicles. So they were formed at one point during the patient's life, but at some point they just got completely obliterated. So I think this gene is so important for that development, which is why embryologically these structures are just completely missing in these guys. I am not an expert on Trikafta. All that I know that it is a CFTR modulator. And good news is that we have seen patients, we've done sperm retrievals on patients who are currently taking Trikafta, and we have seen that the sperm counts and sperm motility and sperm quality don't seem to be affected by the Trikafta. So that's very good news. We still don't have exact data on whether Trikafta is able to increase the serum testosterone levels, meaning the amount of testosterone that are being produced by the testis. We still don't know several questions. If the improvement on the quality of life that is seen in men with CF, nutrition, activity level may all help with future bone density and so on in patients that are taking Trikafta. So what is the good news here? I presented a lot of bad news saying, oh my gosh, there's no tube, there's no seminal vesicle, not enough ejaculate. So what is the good news? Because most men with cystic fibrosis just simply have obstructive azoospermia, meaning there's some sort of a blockage, meaning there's just no tube that takes the sperm out. They still make normal functional sperm. And I think with the help of urologists, these sperm can be used with assisted reproductive technology. And so most men with CF are actually able to father biological children. So this is very good news because that's not true of every guy that shows to my clinic with no sperm in the ejaculate. Unfortunately, I have to give lots of bad news to people saying either because of an underlying genetic condition or because of a mutation that we don't know of, sometimes we may never be able to find sperm in those testes to use for assisted reproduction. But on the quite to the contrary, in men with cystic fibrosis, this is actually very good because most often, 98% of the time, like I said, we never use the word 100% in medicine. 98% of the time, we're able to find sperm within the testes in men with cystic fibrosis. So what is assisted reproductive technique? Patients are always like, doc, okay, you're going to take the sperm. And then they ask me the question, how long is the sperm good for? So sperm is actually good for about 15 years when it's frozen and can be used to father biological children for up to 15 years reliably after. So even in men who are not immediately married, who don't want to think about having a children right away, but just want to get it over with the peace of mind saying my sperm is somewhere, sperm is still good for like 15 years. In fact, I've done sperm retrievals in a few couples with CF who are 22, 23 years old. Doc, we're not planning to have kids for another 4 or 5 years. We still haven't made up our mind. I'm happy to do the sperm retrieval because the good news is that the sperm is good for about 15 years. And so what does happen to the sperm after it is removed? It's used in a technique called ICSI, called intracytoplasmic sperm injection. It was first introduced in the United States in 1992. And so this is an example of a laboratory. You see the ICSI pipette. There is one sperm in there. And this is the huge egg that is being held in place by the suction pipette over here. And you see the catheter being slowly introduced into the egg. What's so fascinating is that the sperm DNA contributes 50% of the embryo, and the remaining egg DNA contributes 50%. But you see how small the sperm is compared to the size of the egg. But it still contributes 50%. So still very important for 50% of the DNA. But really, the only thing that the sperm contributes is the DNA for the first day of life after fertilization happens with the egg. All of the organelles that is required for the embryo truly come from the egg, like the endoplasmic reticulum, Golgi apparatus, mitochondria. All of that come from the egg. The sperm only contributes the DNA. So very fascinating in 1992. So without this technique, biological children in men with CF would not be possible at all. Well, this is the only way for us to use the sperm that is removed. You can't just use something called insemination, wherein you take the sperm, inject it around the into the female cervix with a catheter. You cannot do that because the sperm that we get are so far and few that we could use it for assisted reproduction like this with IVF, wherein the female partner has to undergo all of the expensive hormones and egg retrieval to do that, to be able to actually get to this point of doing IVF with ICSI. So we're going to talk about how to actually get sperm. So we talked about what happens with the sperm once you get it out. But here we're going to try and see if we can actually,
of PISA and PISA techniques for men.
We're actually going to see how to actually do the sperm retrieval. So most of these procedures are actually used in men with vasectomy. So it's almost, if you think about how men with CF present, most of the time it's men who've had vasectomies, which are very similar to men with CF, is how they present. And so there's one way you can use, we prefer the MESA way, but if you have a good epididymis with CF, meaning you haven't lost a lot of the epididymal length, and there is some epididymis, then you can use something called PISA, which is a percutaneous approach. But more importantly, if the epididymis is very small in men with pretty severe CF, then you have to use the microscope to be able to get sperm. And so hopefully this is a video that will demonstrate the two techniques. So PISA is where with 2 fingers, you're able to stabilize the epididymis, and then with a 30 gauge needle, you've given local anesthesia, sometimes can be done in the office pretty simply, and you're able to inject the epididymis and draw back very little epididymal fluid. So it's called percutaneous epididymal sperm aspiration, or PISA. You see the opaque colored fluid that comes, and we're able to see if there's sperm or no sperm. And then MESA is when you're able to, sometimes if you cannot find sperm with this technique, now you probably have to do it under the microscope. And so here you see the epididymal tubules under the epididymal tunic. This is using an operating microscope. We make a small incision in the epididymal tunic, and you see the epididymal tubules are able to bulge out. And with a small microknife, so the patient is actually sleeping for this, so they cannot feel any of these things and they shouldn't be moving. And you see we're able to get fluid from the epididymis, which we are able to extract. This is another patient with CF where you're already able to tell the epididymal tubule under the epididymal tunic here. Most of the epididymis is pretty scarred and vascular and not usable. And that's the place where we actually did the PISA, where we were not able to get sperm, rightfully so, because this was an area of scar tissue. I think everybody now can appreciate that that's where the sperm is likely going to be, because these tubules are dilated, and we obviously are able to zoom in on it and make a very small incision. Patients go home the same day. It takes about half hour to 45 minutes to do this operation. And the restrictions are bed rest for about 1 day and 2 weeks of no heavy lifting. And we often have a microscope in the operating room. We're able to test to see if there is sperm. So with PISA, we're able to see this one moving sperm here. But with MISA, we're able to get actually a lot more sperm, which we can obviously save not just that day, but are also able to use it for up to 15 years where these sperm are frozen. And for the IVF ICSI that I showed you, all that you need is about 10 to 20 moving sperm, and depending on the age of the female. So if the female is young, obviously you're going to get more eggs, but if not 10 to 15 eggs, is 10 to 15 eggs and 10 to 15 good sperm is good. So despite the fact that me showing you all these advanced technologies that exist with sperm retrieval and with egg retrieval and IVF, very few men actually seek fertility treatments, and why. And that's why I think we're all here, just to educate ourselves that there are options and what can we do about this. Some of the research that we've done, both Farah and Catherine are on the call today, are both medical students and Mars scholars working with me this year. We actually did a survey of men with cystic fibrosis at the University of Miami, and we asked a few questions. At what age should we be talking to patients about fertility? But pretty much all of them said that we should be talking to them between 18 to 24 years. We often think fertility is a very taboo topic. They're not getting ready to get married, and they can, wait a long time and let them get married and let's not bring about fertility. Quite the opposite. They actually want early education. And then how important is the inclusion of reproductive knowledge? And about 60% of them said that it's extremely important that they learn about reproduction and options early on with cystic fibrosis. 20% of them are actually currently attempting for fertility. Unfortunately, 70% have never been told that semen analysis is a simple and an easy test to do to check your male fertility potential. Moving on from actual fertility to hypogonadism, which is testosterone. Low testosterone can have lots of consequences. It can have low body mass index, low libido, erectile dysfunction, depression. About 50% of men with cystic fibrosis, because of problems not just with the sperm but with testosterone levels, can have low testosterone. And this could be because of the chronic inflammation, the current infections that happen, the nutritional status that's sometimes poor in CF, and also sometimes steroid use that is pretty prevalent in the CF population. So all of these reasons why testosterone can be low, and men with CF can suffer from hypogonadism. How could you treat this? It's actually fairly straightforward. If your fertility options are complete and you've done sperm retrieval as a young guy and you've had good quality sperm, or you're not interested in fertility at all, there are very safe and effective testosterone therapies that are available that men can take lifelong, as long as they're interested in things like libido, erectile dysfunction, energy, and so on. The testosterone therapy is a very good treatment option. There are certain risks like cardiovascular risk and prostate cancer that need to be discussed and obviously followed along. But as long as you seeking testosterone therapy from a legit doctor and you're compliant with the blood tests that follow up, that risk is extremely, extremely low. Some men with CF actually have a pretty increased risk of sexually transmitted infections because they know they're never going to father children, and so they therefore never use condoms. So they have pretty high prevalence of STIs. But unfortunately, STIs will also decrease the risk increase the risk of infertility, because now that epididymis, where I showed you where we can get the sperm from, infections like chlamydia and gonorrhea will actually cause epididymitis and scar that little epididymis down, decreasing the chances of successful sperm retrieval in the future. So one unfortunately complicates the other, and I think education on this front, I think, is also very important. So in conclusion, I think I've able to stress to everyone that because of the underlying pathophysiology and the mutation and the genetic variants that are present in cystic fibrosis, men will have something called obstructive azoospermia, wherein they make a lot of sperm, but unfortunately the sperm cannot be transported outside because of the absence of the vas deferens. I think from our research, and fairly certain this can be validated outside, most men with CF actually want to learn about their sexual and reproductive health early on at 18. We started at 18 years old. I'm fairly certain if we did this research in adolescence with assent from parents, we'll probably get an answer in a much younger age that they want to know. Fertility is actually not increased by Trikafta. People think once you take Trikafta, everything in cystic fibrosis improves. Fertility does not improve. But one thing we do know, I don't think it actually impacts fertility in the negative way. Fertility options with cystic fibrosis actually exist. The chance of having biological children are there. More and more insurance companies are now covering IVF. Without insurance, the cost around IVF is around $25,000. But most insurance companies, pretty large companies, employers are now mandating fertility coverage for patients in cystic fibrosis because being an underlying medical condition, there's a pretty high chance of getting covered with good insurance companies. And I think we need to sort of streamline this referral process. I think reproduction and sexual health should not be a taboo among both cystic fibrosis patients and doctors who specialize in cystic fibrosis. I think awareness is important. Streamlining referrals are important. Doctors to understand which urologists are interested in taking care of these patients. I think identifying them is important. And at least counseling is important. Whether patients pursue these treatment options or not, for different reasons, financial reasons, emotional reasons, don't want to think about starting a family reasons, I think all of that is fine. But at the least, counseling needs to be provided. Awareness needs to be important. And so patients and doctors need to be aware of the options that exist and let the patients make the decisions. I think that's what is probably very important. Doctors often make the assumption that patients don't want to know about this. And so therefore, we don't counsel them because we think that they don't need to know. But quite to the contrary, I think patients want to know and be in charge of their care and their medical condition. With that, I'd like to thank you all for the opportunity. Obviously, thanks to the Cystic Fibrosis Foundation for supporting our research here at the University of Miami with Dr. Tupiachi and her group. And this is my Twitter handle and my Instagram handle. A lot of these youngsters don't email anymore, so I stopped putting my email address over there. But I'm very happy to take questions through these social media channels. But very happy for the opportunity and thank you all.